Hi everyone, welcome to another Monty Hart lecture series. Today we have Dr. Sadiya Khan, who will be speaking about preventing cardiovascular disease with the PREVENT equations, New Year, New Insights. It's a real honor to have Dr. Khan here today. She is the Magistrate Professor of Cardiovascular Epidemiology and Associate Professor of Medicine, Preventive Medicine, and Medical Social Sciences, and works as a preventive cardiologist as well. She's the inaugural director of the Center of Population Science and Aging, with clinical expertise and research focus on prediction and prevention of cardiovascular disease. Dr. Khan's research efforts are supported by multiple grants from the National Institutes of Health and the American Heart Association. Dr. Khan has published over 350 peer-reviewed scientific research publications in leading medical journals and has an H index of 47. Her original science has been highlighted by the AHA as among the top advances in heart disease research for 4 consecutive years from 2020 to 2023. She also serves in key leadership roles within the AHA-ACC, including as the chair of the AHA working group that developed the PREVENT equations. It's a real honor to have you here today. Thank you so much.
Thank you so much for the kind invitation and really generous introduction. I'm excited to talk a little bit about prevent risk prediction more broadly and conclude a little bit with how we can perhaps implement this into our prevention algorithms, and excited for the discussion that follows. I have no relevant disclosures. So I'm going to start with a little bit of an aspirational question. Can you imagine a world free of heart disease? It may seem almost fantastical and not realistic, but I'd argue we actually have to think this way and think as big as we can before we may achieve something at least close to this. And if we want to actualize this goal, I think there's 3 key steps that we need to achieve. First, we need to understand where we are. What is the contemporary burden of cardiovascular disease and its subtypes? What is causing morbidity and mortality in the current day? Second, we need to determine who's most likely to develop cardiovascular disease and specific types of cardiovascular disease. Because if we don't know who's at risk, we won't know who to prioritize for prevention. And third, this is perhaps where it's the most challenging aspect of what we do in clinical practice. How do we implement available, highly effective therapies that we are now have the privilege of having accessible to us to reduce the risk of cardiovascular disease? So in order to accomplish these 3 steps, we're going to talk a little bit about 3 goals today. First, to describe this burden of cardiovascular disease. Second, to talk about the current approaches to risk prediction and how we incorporate cardiovascular disease and its subtypes. And third, review briefly the available evidence base and what the gaps are for risk-based prevention of cardiovascular disease. To get started, I think it's helpful to take a look back in the past and think when the rise of heart disease mortality and CVD mortality really started. You can see after the flu epidemic in the early 20th century, heart disease was starting to climb in the 30s and 40s. And at that time, a very famous cardiologist, Dr. Paul Dudley White, who was one of the founders of the American Heart Association, was quoted as saying, "We know the hypertension may be an important compensatory mechanism, which should not be tampered with even were it certain that we could control it." And how far we've come from there to understand that lowering blood pressure is a highly effective strategy to prevent cardiovascular disease. But we can understand a little bit at that time, there wasn't that appreciation for how we can control risk factors, and there weren't tools to be able to do it. If we fast forward a few decades later, we see this inflection point and heart disease starting to decline. And some of the key events that happened around this time may or may not be related causally, but of course, the Framingham Heart Study, which is the legendary, really seminal cohort that really began observational epidemiology, was commissioned in the 1940s. And the term risk factors itself that we use so frequently every day was coined because of this study that helped to identify smoking, high blood pressure, high cholesterol as these risk factors, causal contributors to heart disease. As that decline continued, there was positivity and progress in terms of availability of therapies and advances. But if we shift into the 21st century and take a look at the last 2 decades, we see that the progress for ischemic heart disease has really continued. While there are significant race and ethnic differences in rates with higher mortality rates for non-Hispanic Black and non-Hispanic Black males and females compared to their counterparts, we see this continued decline. Unfortunately, where we see a reversal occurring and perhaps the shift that may be further explained by underlying risk factor changes in the population is increases in heart failure mortality. We see the same disparities with higher rates for non-Hispanic Black men and women, but overall a pattern of increases. Some of this is not a surprise to any in the audience. We know that obesity is on the rise, which is highly linked with heart failure, hypertension with poor rates of control, prediabetes, and diabetes. So these are adverse patterns that we're all seeing and are contributing to this reversal in heart failure mortality. I think another thing that's really important as we look at the epidemiology is that there's also a growing burden in young adults, individuals who normally we don't take into account in the pooled cohort equations for risk prediction under the age of 40, but yet we're seeing really significant burden of obesity and diabetes that's increasing. Obesity prevalence is up to 43% in young adults, and diabetes prevalence is up to 4%. These trends do not look like they're going away anytime soon, and forecasting analyses by the American Heart Association suggest that 61% of US adults will have obesity by 2050. 81 million adults will have diabetes, and all of this will lead to 1.8 trillion in projected healthcare spending if no intervention is made. I think all of this coming together is best encompassed by the word tsunami. And this growing tsunami of cardiovascular disease, kidney disease, metabolic disease that's occurring in the United States needs urgent action. And so what can we do to really start to interrupt this adverse pattern that we're seeing? So one of the things that I think is necessary is being able to define and outline what is needed to happen. And so that I think really sets up the need for a new prevention paradigm, one that accounts for these three axes that are complexly interrelated: metabolic disease, CKD, and CVD. But also not just that they co-occur, but that they have this synergistic relationship where higher risk occurs when they are both present. For example, if someone has diabetes and CKD, the risk is 3 times as much as either condition itself and leads to earlier onset of adverse outcomes. So that's all very dismal and disappointing and may seem a little bit depressing, but there's hope. And I think we're in the right time and we have the right opportunity right now to be able to do something about this. There's better scientific understanding than there ever has been about these conditions and their pathobiology. There's multiple novel therapies, and we'll talk a little bit about these. And there's evidence for multi-system impact from these therapies, where I think we're starting to move beyond this idea of a medicine is for treating diabetes or for treating kidney disease, but rather it's for treating all of these things to improve CVD outcomes. All of this really led to the impetus for the cardiovascular kidney metabolic syndrome construct definition led by the American Heart Association that culminated in a presidential advisory and scientific statement synopsis that really helped experts in the field come together, and we were able to say, how do we best define this so that others, clinicians, researchers, patients, policy experts can take this construct more comprehensively and holistically. The simple definition that we came up with, although maybe isn't so simple, was to say that this syndrome is a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity that together lead to poor health outcomes. Within the documents themselves, we outlined this staging system to really highlight the fact that people can progress across the stages, leading to higher and higher risk of cardiovascular disease, but also importantly that there can be regression with optimization of cardiovascular risk itself. While stage 4, once signs and symptoms of coronary heart disease, heart failure, AFib, stroke, or PAD are present, feels like a final stage, the earlier stages, 0, 1, 2, 3, focus on prevention of cardiovascular disease morbidity and mortality, and how potentially regression may be feasible. A key aspect of this definition was to understand how risk plays a role, particularly predicted risk and quantitative risk, both from chronic kidney disease as well as using risk calculators. And this really sets us up to switch to the next section, which is in order to understand who's at risk, we need to appreciate what our approaches are to risk prediction and what things are we predicting within cardiovascular disease. This figure, I think, really helps to highlight the conceptual approach that we've had for several decades in cardiovascular disease prevention. This idea that we want to match the intensity of our therapy with the risk of the individual. And that really comes from the fact that we know that in a given population of individuals, there's a gradient of risk. You see that in your clinic every day. And if you're seeing a dozen people, what you want to know is who is the person or few people that are going to go on to get cardiovascular disease so we can maximize treatment benefit. And that, I think, is really predicated on having the most accurate risk calculator possible. If we think about the fact that this is the current standard, there's several guidelines that have implemented and recommend risk-based prevention approaches. The blood pressure guideline, the cholesterol guideline, primary prevention guidelines, and even most recently, a couple years ago, the guideline for the management of heart failure incorporated multivariable risk assessment in their guideline as a recommendation for assessing risk for heart failure. All of this is predicated on the fact of having an accurate and contemporary risk model. And as we were developing the CKM construct, it became apparent that in the present day or year, there were new risk prediction needs that needed to be addressed to optimize treatment for our patients. And I like to think about this in three big buckets. First, who's the population that we're talking about? Who are the patients that we are trying to manage and prevent cardiovascular disease in? Second, appreciating and acknowledging the growing burden of cardiovascular kidney metabolic syndrome. And third, how do we think about this from a life course perspective? And within those categories, I think for population, the generalizability, having a diverse sample in the derivation and validation of the model development, having contemporary modern data that accounts for these changes in risk factors and treatment patterns that we've seen. For cardiovascular kidney metabolic syndrome, including outcomes like heart failure, whereas the pooled cohort equations had only included ASCVD. Thinking about predictors that are relevant, particularly for social risk or kidney disease risk or metabolic predictors. And then within the life course perspective, as we see younger and younger patients coming in with preclinical disease or with disease, we need to make sure that our risk equations also cover a longer time horizon and expand that age so we can actually intervene before disease is present. All of this culminated in the scientific statement and methods manuscript for the development and validation that are shown here. And I'll go through a little bit some of the details of the model itself and then do a bit of a comparison with older models as we talk through this. So the prevent equations, the populations that we use to derive the models are shown here. This was under the umbrella of the CKD Prognosis Consortium led by Joe Korash and included population-based cohorts, so similar to the pooled cohort equations, using research-based cohorts like MESA, Cardiovascular Health Study, Jackson Heart Study, Framingham Cardia, and ERIC. But we also expanded to leverage the availability of EMR data to really be able to expand and say, we want the largest, most generalizable sample of primary prevention patients so that when we apply this to our patients, we can say this is relevant to you. And so we included Optum and Geisinger as well. In terms of the predictors that went into the model, we really wanted to focus on causal risk factors or those that have strong associations with cardiovascular disease. And you'll see, no surprise, similar to the pooled cohort equations, blood pressure, antihypertensive treatment, cholesterol levels, diabetes, smoking. But importantly, since the pooled cohort equations were developed, there's a growing recognition and within the CKM framework of kidney disease, so EGFR was included. As statin use has become much, much more commonplace, we didn't want this model to exclude people on statins, And we were thinking that there's going to be therapies beyond statins that we may want to be relevant to the model. And so we included a predictor for use of statin therapy. As we incorporated other outcomes, other predictors like BMI came up, which we know are strongly associated with the risk of heart failure. And the third thing we talked about was what about add-on or subsets of the population where certain biomarkers may be important, like UACR in patients with diabetes or hypertension, or with chronic kidney disease, A1C in patients with diabetes, or more broadly, how do we start to incorporate social risk with the SDI? The outcomes are shown here, which were a composite for the total CVD or the primary outcome of ASCVD and heart failure. We also separately created equations for ASCVD itself, I think thinking forward to how this might be used for statin or non-statin lipid-lowering therapies, and heart failure for other therapies related to heart failure. Here are the baseline characteristics of the sample. As you can see, the derivation sample and the validation sample both had about 3 million individuals. All of the analyses were stratified by sex to account for biological differences related to predictors and outcomes. The mean age was in the 50s, consistent with the US population. The racial and ethnic diversity was shown here and had a good sample of Black adults, Hispanic adults, and Asian adults. And the risk factor levels are shown here. In terms of basic model performance, you can see here for total CVD, ASCVD, and heart failure, I show the number of events. So we had adequate numbers of events, the C statistics, which ranged very nicely from 0.76 to 0.83, and the calibration slopes, which essentially plots the predicted risk with the observed risk. So a slope of 1 is perfect unity, and we see all of these estimates hover around 1. Now, the natural question when a new model is developed is, how does it compare to the prior model? And the pooled cohort equations are guideline recommended risk equations that we know and have been around for a while. And so we wanted to compare that in our validation sample as well. And I think it's important to note that the C statistic for both prevent and pooled cohort equations were very similar. We see 0.73, 0.77, but the calibration slope was what was different. And this really, I think, highlights the importance of contemporary data, whereas the pooled cohort equations were largely derived from data from the 1970s and overestimated risk by about twofold, despite being highly correlated with the prevent equations. So the calculator is available online. The QR code is listed here. You can access it on a mobile device or on your computer using the link there. And I think it's been really, really exciting to see how many people have accessed the website through reviews and users, as well as distinct sessions, and really showing how interested people are in being able to access and utilize this. There's also code available for those who are interested in using the tool for research through the American Heart Association that can be downloaded as well for free. So I mentioned some of the key differences between the development of the prevent models, but I wanted to highlight, again, in those 3 kind of categories for population, predictors, and outcomes, how the prevent models differ and why some of the differences that we're seeing in risk estimation may be relevant to how they were developed with the intent to predict risk of CVD. So as I said, there were over 3 million individuals. We spanned 1992 to 2022 with cohorts and EMR data. Predictors are shown here, including the novel predictors. And we talked a little bit about expanding the time horizon. So the outcomes of the model include 10-year and 30-year risk. And so if we compare and kind of go through a similar assessment for Framingham and pooled cohort equations and go kind of across temporally, you see that overall, one of the things that I think is wonderful to see with time, we've expanded our data sets. We're using more and more samples that are more broadly generalizable. This allows us to incorporate more predictors that are relevant and then expanding our outcomes so that we're really being comprehensive about prevention. I wanted to run through an example calculation to try to highlight a little bit of what the value of having some of these new predictors in the equation are. So this is a hypothetical 55-year-old female with the cholesterol levels shown there, blood pressure, not on antihypertensive medication or statin medication, and doesn't smoke. And so you get a risk as you would expect. I'm sure if I asked you, you would have guessed somewhere in the 2 to 3% for a healthy 55-year-old female. But if we modulate the kidney function or having diabetes, you see almost doubling in risk, 5%, 6%. And then thinking about that synergistic outcome, if someone has kidney disease and diabetes, same profile, now our estimated risk is 12%. And we've crossed an important threshold that we may be wanting to think about therapies for. I do just want to highlight a few considerations as we've talked a lot about the model and thought about what are the future considerations as we think about the implementation of the model. I think one of the most important things in these conversations has been how we consider the social construct of race, consider social determinants of health. Biomarkers are becoming increasingly available and are not included in the base model, but is this something that should be considered in the future? And third, and importantly, how do we use the model on a practical standpoint for what are the thresholds that we would need to say now somebody warrants treatment? So I'll start a little bit with kind of just a brief comment on each of these three topics with focusing on this idea of race and bias in clinical algorithms. This has really come to the forefront in the last several years with a high-profile paper in the New England Journal that really talked about a broad swath of clinical algorithms across medicine that incorporated race correction. This wonderful systematic review in the Annals of Internal Medicine that highlighted how race and ethnic disparities impact algorithms and treatment recommendations. And the National Academies has also put forth its own report on what the consequences and effects of these race-based algorithms may be. And I think all of these really come together to highlight the importance that race as a social construct is not a biological driver of risk, but of course there are differences in risk because of these root causes of disparities. So how do we put those things together? I think one of the things that's important is to understand how the model performs in different racial groups as a means to understand whether or not a diverse sample has been incorporated into the development. And so these show the calibrations by demographic subgroups for Asian adults, Black adults, Hispanic adults, and white adults. And overall, you see largely that there's similar estimation or calibration for the prevent models across groups. And when you compare it with the pooled cohort equations, you see a systematic overestimation across the different groups. If we take a look at the samples, I think that's also really helpful. We had, over 2 million white adults, nearly 300,000 Black adults, nearly 200,000 Hispanic adults, and about 80,000 Asian adults, compared with the pooled cohort equations that only included white and Black adults. I think the other thing that we're going to see more and more of and will be very helpful are data that help us see how well the models are doing in different populations. This is an analysis that was presented at the American Heart Association by colleagues that looked at the VA database and said, how well do these models that did not include veterans perform in the VA, and how well do they do across race and ethnic groups? And you can see in these calibration plots for the CVD model, for the ASCVD model, and the comparison with pooled cohort equations, which very nicely shows that overestimation again in a sample of over 2 million adults. We saw very good calibration for the prevent models and very consistent calibration across race and ethnic groups within this diverse sample. We've also seen data now from the Kaiser Permanente Northern California system, which is highlighting the importance of being able to evaluate these models across race and ethnic subgroups. And similar to the prior slide where we saw overestimation with the pooled cohort equations shown in red in every race and ethnic subgroup, we see very similar calibration, close to 1 for the prevent model, both the base model and this full model that incorporates UACR, A1C, and SDI. And then the Kaiser Permanente group also has their own model, KPAR, which they show is very similar to the calibration for prevent, which is very reassuring as well. I think all of these really raise the question of how does race and ethnicity and social determinants of health play a role in risk prediction? And I think this quote is very, very helpful and came up as something that I think helps to center us on what we are trying to do when we think about not having race as a predictor in the models, but we do have SDI or the social deprivation index in the model. And I think this is really helpful. If you really care about these issues and want to make a difference, you must not use race as a proxy for poverty or poverty as a proxy for race. They intersect and overlap, but to really understand the health of this country, you have to be more sophisticated than assuming that only poor Blacks are affected by this crisis. Look deeper, think differently. And I think this really resonated with me because I've seen a lot of conversation around, well, prevent replaced race with SDI. And I think that this really highlights we're not trying to replace the effects of racism that do exist, but rather highlight what are the social variables that we can include rather than using proxies. And this is very relevant. I think the social place-based context for CVD risk is important, and how we can best capture that is probably a question. But this is from a review article that we did a couple of years ago that highlighted in three cities, Chicago, Washington, D.C., and New Orleans, which have some of the largest life expectancy gaps in the single metropolitan city. I think in Chicago, we have about a 30-year age gap across a 7-mile radius. That highlights when you look at the patterning of coronary heart disease in this example and overlay it with social vulnerability index, which is a similar index to SDI, it really maps along those lines. And so thinking about how risk assessment can incorporate this for our patients, I think is helpful, although not sufficient. We do know that when we considered SDI, there are a variety of place-based indices that have similar performance. This was the variable that was available to us in the health systems. We used zip code level, and I'm showing you here, even in a single metropolitan city, there's a lot of variability. So I think this is just a first step. And third, and most importantly, patients aren't going to actually be able to modify where they live as a way to improve their risk, but we have to think about how we can address social determinants of health as we're considering risk assessment and prevention. Biomarkers are, I think, another exciting area that need a lot more work as we think about cardiovascular disease risk assessment. I think so far they've been a little bit disappointing, and these are data from both add-on to Framingham as well as pooled cohort equations for CRP, carotid IMT, ABI, PRS. And of those, you can see from the percent reclassified and the net reclassification index, it's been largely disappointing, except for coronary calcium. And I would argue, well, you're actually just detecting disease, and so it's helpful from that perspective. I do think as we start to include heart failure in our risk prediction algorithms, we're going to see a shift in what biomarkers may be useful. This is a really nice observational study that looked at the association between different biomarkers and associations with incident heart failure, both HFpEF and HFrEF. And I think we all know that BNP is a great biomarker. High sensitivity troponin is a great biomarker, but there may be others out there that will be helpful as we think about what can we add on to the PREVENT models to really reclassify risk. I do also think it's important as we think about these scores is how we're going to use them. And that's where thresholds come in. The score itself, the goal is to most accurately predict risk, but the threshold is what tells us when to act, how to recommend treatment, and when to do that. And so one of the things we wanted to highlight when we published this viewpoint just a few months ago was that even though there's a new model, I don't think yet we're at the place where we know what to do with it until new guidelines are available. We wrote that the foundational principles discussed in the 2013 guidelines remain relevant. We need to be able to use predicted risk, but we can now estimate it with greater precision. And I think this really leads into this idea that how we use risk prediction to determine thresholds matters. And so if we go back to 2013, and this is an excerpt from the guideline supplement that highlighted why this 5% was classified as a borderline risk category and 7.5 was classified as a treatment threshold for recommendation for statin therapy with the pooled cohort equations with a clinician-patient discussion was really related to this balance of number needed to treat and number needed to harm based on the adverse effects of diabetes. And so you can see, based on an annual rate of about 0.3% and a 10-year risk of about 3% of new onset diabetes from the cholesterol treatment trialists, that was kind of the bar. So number needed to harm of about 100. So you could see that benefit kind of goes down to about 3%. if we consider the risk of new onset diabetes. Now, we can have a discussion that perhaps that's a trade-off that's worthwhile to prevent cardiovascular disease, but let's say at least there. And so then, because it was known that pooled cohort equations overestimated risk, 5% was considered borderline for moderate intensity. And then when we lower the number needed to harm based on high intensity, the 7.5 really became the number for the threshold at that time. And if we think about the fact that the models now are more accurate and more closely predict risk, well, perhaps it's time to lower that threshold. I think that's the question that is up for discussion as we think about the new guidelines. And I think it's helpful to say the context of the development of the models is very complementary, but distinct from the guideline process itself. And so both the pooled cohort equations and AHA prevent models have been developed in tangent and parallel with their use in guidelines, but the guidelines have informed their own decisions on thresholds. And we know ACC/AHA have planned upcoming guidelines that are set to be released in about a year for both cholesterol and CKM that will help to inform this discussion. I just wanted to spend the last 10 minutes or so really talking about what do we now have in our armamentarium that also supports the relevance of a broader risk model, how we can consider that risk model, and what we can do for our patients? And I think the emergence of these therapies that target all of the axes of cardiovascular kidney metabolic syndrome, kidney disease, metabolic disease, reduced cardiovascular disease risk, help us really see this path forward now that where we move beyond statins, or perhaps more importantly, just beyond lipid lowering to reduce risk for cardiovascular disease, to think about risk for heart failure, to think about risk for kidney failure as relevant outcomes. And so I think these three are really the highlight of what the last decade has seen. So just briefly, for each of these therapies, I think the evidence base continues to grow. It's exploding every day. I just wanted to highlight a couple of studies. So if we start with SGLT2 inhibitors, really these medications were originally identified for diabetes treatment, but interestingly, their glycemic effect is quite modest at best. And then when we started to look at outcome trials, two outcomes really came to the forefront, and that's hospitalization for heart failure and kidney-related outcomes. This was a really nice systematic review that we published in JAMA Cardiology a couple of years ago, led by Darren McGuire, that took the available SGLT2 inhibitor trials at the time, EMPA-REG, CANVAS, DECLARE, CREDENCE, and VERTUS, and looked at these specific outcomes, so heart failure and kidney-related outcomes. And I think the thing that's really impressive is how similar the benefits are for both of these outcomes, with really consistent 20 to 40% reduction in events. So if we look at the second one, GLP-1 RA therapies or dual agonist GLP-GIP, this has become really the conversation for, I think, the lay public. The number of papers that are coming out considering these therapies, I think, is really, really such high volume. So I wanted to focus on the three trials that we have that included primary and secondary prevention patients that had outcome data, and kind of put them head to head and think about what do we know about the GLP-1s right now. And I think the first thing across the three trials to point out is that these are high-risk patients. So if you look at the MACE event rate in the placebo arm, you see a very high event rate over a 1 to 3 year period. And so these are not the average patient that we're seeing with diabetes or with CVD, but really a risk-enriched group for the trial. And so across the three trials, SUSTAIN 6, which included patients with diabetes, nearly 80% of whom already had prevalent CVD, SELECT, which specifically included patients with CVD but without diabetes, or FLOW, which included patients with diabetes and kidney disease. I think the consistency across the three is that we have middle-aged, high-risk patients with a very consistent benefit on MACE, so 20 to 30% reduction of MACE. Now, the problem, of course, is that when we think about the eligibility criteria and we think about the patients who may benefit from the therapy, well, that's a really, really large number. Nearly 140 million people in the United States would qualify for either overweight or obesity, diabetes, or cardiovascular disease. And so, as we start to think about how we can use this therapy, it's going to be important to think about risk and benefit. In terms of the nonsteroidal MRAs, I think this has also been one where we've seen very targeted heart failure and CKD benefit. This is a nice review that looked at the two trials of finerenone in patients with diabetes and kidney disease, Figaro and Fidelity, and looked at the overall benefit on MACE, which had about a 24% reduction, as well as on kidney-related outcomes, which had about a 23% event reduction. So again, showing consistent benefit for CKM syndrome in patients with diabetes and CKD. One of the interesting questions that's come up as we think about these therapies, we're now in an era where we have multiple therapies available to us. Well, which one do we start? Are there additive benefits? Do we think that one is better than the other or that they work together? So this was a really nice modeling paper that looked at all of the trials for patients with diabetes and CKD and asked the question, what happens when you add on, particularly for MACE, hospitalization for heart failure, cardiovascular death, as well as CKD progression and all-cause mortality? And you can see that really nice additive benefit with each additional therapy, and importantly, with the three together, much greater benefit than with any single one alone. And each single therapy has a similar benefit. And so seeing that additive effect, I think, is really enlightening as we start to think about how we might want to consider these therapies for our patients. I just want to pause though and say I'm really excited about these therapies. They are really pushing our knowledge of pathobiology, but it can be a little bit overwhelming, I think, both as a clinician and also for our patients. And how do you think about sequentially adding them? And this movie always comes to mind as we start to talk about these therapies because it's really been an explosion. It's wonderful to say that we are in the having this issue of too much of understanding what to do. And so are we in this place where we want to do everything everywhere all at once for everyone? And I'd argue perhaps not. And I think what we need to do is think a little bit about what are the risks of the therapies? What are the benefits? How do we get to that net benefit that we talked about with the statin therapies? And also cost. And, one of the things that we proposed in our scientific statement was this concept of absolute risk reduction, which is a direct product of the absolute risk or the predicted risk with PREVENT and the relative risk reduction or that hazard ratio from each therapy can give you a number that can identify who is most likely to benefit. So the higher the absolute risk reduction, the more likely for benefit. And you can see in this figure that if your baseline risk is higher, the individual in red, even for the same therapy, your delta, how much you're going to benefit, is much more than the individual in green who started at a lower risk. It's just about switching to an absolute scale. If you're much higher risk, you're more likely to have an event. You have a lot more benefit or room to go. So I just want to conclude with a couple of takeaways, kind of thinking about all of those things together. How do we move towards a world free of CVD? Well, first, I think we have to acknowledge that the burden and phenotype of cardiovascular disease is shifting. We're seeing a growing prevalence of CKM syndrome, particularly among young adults, and I think that's a priority area for us to think about in prevention. PREVENT accurately and precisely predicts risk for cardiovascular disease as well as the subtypes AS, CVD, and heart failure in a diverse sample of adults, and we incorporated predictors and outcomes relevant to CKM syndrome. And third, our future research should really focus on external validation of the model. We're starting to see some good signals, but making sure that we're staying contemporary, assessing and addressing, more importantly, social determinants of health, and implementation of these novel CKM therapies with guidance on how, when to use them, and what risk thresholds are important. And while we didn't spend time today talking about it, I think we all know what the gaps are in terms of implementation for even inexpensive therapies like statins and blood pressure medications. So those barriers and challenges are even bigger when we start talking about newer, expensive therapies that may not be easily accessible. And so I think we have to think about that as well as we think about the implementation. So I'll stop there. Thank you so much for your time and attention, and happy to take comments and discussion.
Thank you so much, Dr. Khan. That was a wonderful lecture and a very important topic, and we can see how much work and how complex it gets to make some of these decisions and what to exclude, what to include, and because it's never perfect, it's always a trade-off. I think so for everyone, please put your questions in the Q&A. If you have any, I'll start with one question, and it's related to age. I agree with you that as we see changes and worsening, health conditions for the young, and we wait too long to re-stratify these patients, there's a huge potential for early treatment in younger populations. How is the performance of the prevent, or is it good enough for the young? Is there differences in performance, young versus old?
Yeah, that's a great question. One of the challenges in the age range for risk prediction is the time horizon, right? When you think about young people, they're not going to have an event in the next 10 years. And so it was important that we have a really big sample. And I think we were able to accomplish that by using EMR data as well. So we started at 30. And when we look at the calibration, I think to your point, in the younger adults, we see similar calibration in the 30 to 39 as in the older 70 to 79. And so I think we were able to manage that, but I would argue that perhaps tenure risk, even in 30 to 39-year-olds, even though we can calculate it, is always going to be low. And so that's where that 30-year risk and thinking about how we can pair them in our conversations is really important.
Thank you very much. Yeah, it's very tough. I guess maybe you think imaging maybe will help in these patients to see who has subclinical CAD in the younger, right? Based on prevent, maybe.
So that's a really interesting question too. And I think the challenge that comes up is who will benefit from imaging and when does CAC really develop to be useful? And we know that under the age of 40, CAC is really not that prevalent. And so I do think there's a question around, are biomarkers helpful? Are other risk enhancing factors helpful, like family history? I think we're really excited to see about the new LPA trials. Is ApoB helpful? So I think it's a starting point, but all of these are really important questions as we zero in on young adults. I think we've largely ignored young adults because it's been well, it's not going to happen in the next 10 years. So we'll get there when we get there.
Yeah, perfect. Thank you so much. We have a question from, I think probably from our fellows. Until the new guidelines on cholesterol management based on prevent are released, how do you recommend we use prevent model? Does it make sense to use prevent to discuss risk with the patient, but still use full cohort equation on decision on to start statin? Great
I think
question.
it's a really great question. We're in this in-between spot right now, and I think it's important to say that we want to be transparent with that communication with our patients. And we know that right now, for the guideline recommendations, I would 100% agree with the latter point. We should be using the pooled cohort equations to determine when to start a statin because that threshold is tied to that risk equation. And so I think it would be premature and inappropriate to use a 7.5% threshold in the new prevent models. That said, I really like your point that if there's more tools available, can we share that additional risk information with that context, particularly around CVD and heart failure risk, which weren't even available before. And so I think that can be helpful, although not yet actionable.
Thank you very much. From Rob Osfeld, thank you for a wonderful talk and thank you for outlining these important updates in screening. Given that we know that a cardiometabolic tsunami is upon us and growing, that 75% of the US consumes a poor diet, he says, I believe our approach needs to be flipped on its head. I would suggest that we focus much more in a multifaceted way to attempt to achieve lifestyle changes throughout a lifestyle. Uh, assessing assessing risk is important and stemming the tide maybe more so. I am interested in your thoughts regarding how on a population level we may be able to impact lifestyle changes.
Yeah, this is a really great point, and I think it's critical if we think about cardiovascular disease as a non-communicable disease, and yet I think we have individualized it to the point where we've lost sight of the population strategies that have been very effective for communicable diseases. And I think we need to think about that from a public health perspective. So the food environment is a critical place where I think policy level changes are needed. Sugar sweetened beverage taxation is an example. I think reducing sodium in our foods, removing ultra processed foods. There's a lot of work that does need to be done. And I think there's a great quote from a Sandra Galea book that is basically, if we want to be healthy, we need to create a healthy world. We can't ask people to be healthy in an unhealthy world. So I 100% agree with that. Physical activity and other changes are also very challenging things, I think, in our environment, but we do need population strategies for this.
Thank you very much. We have from Daniel Lorenzati a question. He says, thanks for that comprehensive overview. Despite the significant increase in race, ethnic minorities representation with the PREVENT score, the overall proportion seems suboptimal compared to non-Hispanic white. Do you think there is still a need for more long-term diverse cohort studies?
Yeah, absolutely. I mean, I will say my bias is I'm an epidemiologist, so I will always say yes to that question. Um, like with any, I think, model or study, it's a starting point, and we want to make sure that we're continuing to expand and ensure inclusivity and generalizability. And so some of the data that I shared from Kaiser, especially in the California region, they have such an enriched population of Asian Americans that show great diversity in the veterans system, but also how we can use some of the other cohorts that have been very focused, like Masala in South Asian adults. I think like Seoul that is focused in Hispanic adults, and how we can really leverage some of these additional resources to ensure that we're assessing risk accurately and equitably across populations.
You very much. We have from Anchor, one of our fellows. Thank you for the talk. He says his question is on guidance on how to use LP(a) along with PREVENT to stratify patients in the clinic. Is there any data already on that?
So this is a great question. We could probably spend another hour just talking about
Mhm.
LP(a), and I'm sure you've either had a speaker on this topic or will at some point. Right now, the ACC/AHA guidelines do not recommend routine testing of LP(a), and I think there's a couple of reasons for that that are very reasonable. We don't yet have any therapies that reduce or lower LP(a), and so until trials that are ongoing come back positive, not just completed, come back positive to show that we can actually reduce risk with a targeted therapy, I think it may not be as helpful. From a risk assessment perspective, LP(a) is an independent risk predictor, but it may not change overall risk assessment. When it's been added to pooled cohort equations, it hasn't actually changed that delta C statistic or discrimination like the table I showed you with the other models. That doesn't mean it's not useful. And I think, many of us do test it, especially in our young patients with premature onset of ASCVD, those with a family history of ASCVD, to try to understand, is there an underlying vulnerability? But I don't think population screening is quite there yet because we don't have an actionable approach to it.
Thank you very much. Very good point. And there are so many different opinions based on this, and
There
people get
really are. Yes.
passionate each way. But yeah, I agree. So a question that I think is a little bit tough, but important on the removal of race and social determinants of health. The question is, the population obviously was mostly white, and we're using just one social determinant of health. Is that enough to fully remove race without causing harm by it, do you think, or what are your thoughts on that?
Yeah, I think the population it was fairly diverse. The US population is also largely white, so I think we were representative. We definitely did not have adequate representation of Hispanic and Asian adults, so I think that's where some of the limitations were. In terms of the decision to not include race as a predictor, I think there were two big reasons. One was related to the concept that it is a social construct, and so not reinforcing the fact that there may be misperception of biological differences between race groups. And while it could be used as a proxy or a surrogate for experiences of racism or adverse social factors, we wanted to make sure we actually included a variable that measured social factors rather than a proxy or surrogate for it. But I think to your second point of could there be unintended harm, I think that was very much front and center in our thoughts. And so one of the things that we thought was very important was assessing calibration in different race and ethnic subgroups. So even without the race covariate, does it actually change how well the model is doing? I think this piece of with or without race in the model not significantly changing the risk assessment kind of helps to confirm that there isn't harm. And in fact, I think helps to make the point that we are not considering race as a biological predictor.
Great. Yeah, very good point. Thank you very much. Well, that was a wonderful lecture, and we look forward to reading more and learning more about Prevent with future papers and your work, and hopefully we can collaborate in the future as well.
Wonderful. Thank you so much for the invitation and really wonderful discussion. I really appreciate it.
Thank you. Bye bye.
Take care.